Hi, this is Kathleen Richardson from Marymount University, and I am reviewing a clinical practice guideline for evidence-based practice class. The guideline that I chose was the Guidelines for Field Triage of Injured Patients, recommendations from the National Expert Panel on Field Triage 2009, and it was retrieved from the AHRQ National Guidelines Clearinghouse in November of 2011, and this was an update to the previous guidelines from 1999. I chose this clinical practice guideline because of my emergency department experience and background and concerns of overuse in the different emergency departments, overcrowding, and potentials for over and under triaging people to the emergency department. Currently, emergency departments are overcrowded. The numbers of emergency departments are going down. The number of non-emergent patients are increasing, and personnel availability is decreasing. The number of uninsured patients is rising, and reimbursement is going down. According to the clinical practice guideline and the literature review that was done, the annual fixed income in a medium level emergency department is about $2.7 million, and the cost of injury is greater than $400 billion over the United States, with $80 billion in medical and $326 billion in productivity loss. So it's a huge revenue concern to get triage appropriate. We want to make sure that there's enough care and that it's appropriate and given at the appropriate level. The major outcomes that were considered in this particular clinical guideline were the incidence of traumatic injuries, which, like I said, are happening every day, the number of transport calls, the accuracy of field triage. If someone is under triaged, they may not receive the care they require, and they could die. And if they are over triaged, you may bring someone to the emergency department who does not need the trauma resources to improve and to get better. So now you've tied up the EMS and the trauma resources on a patient who doesn't require them, and that may preclude someone who does require them to not get that resource. So that is a big consideration and for the morbidity and the mortality of the patients. And the disability results could be anywhere from something minor to major or even death. So that's what was considered. The guideline objectives themselves were very clear and concise, and from that I was able to develop a clinical practice or clinical guideline or inquiry question. The purpose or objectives were to assist EMS providers with field triage and medical management, to assist EMS providers in making critical decisions necessary to increase the likelihood of favorable patient outcomes, and to revise the 1999 decision scheme for field triage. Even though, like I said, the question wasn't specifically stated, it was very easy to develop that clinical question, which I've provided for you. The applicable population is very, very broad. It's people who sustain traumatic injuries in the field. Well, that can be anyone from any socioeconomic status, all ages, from cradle to grave, all locations, all genders, because trauma doesn't exclude anyone. So it's very applicable to a large, well, to everyone actually. Stakeholder involvement was very important, and they included almost everyone that should be involved. They had a 37-person team on this committee that included EMS, physicians, nurses, medical directors, trauma surgeons, the auto industry, because a lot of traumatic injuries are vehicular, public health, and federal agencies such as the CDC and the National Highway and Traffic Safety Administration of Emergency Services. The who they didn't include, which I didn't find, was a section on patient views and what their preferences are. In a way, they may have covered that because anyone in the committee is a potential patient, so perhaps they didn't think they needed to involve previous patients, but that is an inference on my part. So that not addressing that or how they covered that, I think is a negative part of this clinical practice guideline. But they did definitely define the target users, which are anybody that works in emergency medicine, the advanced practice nurses, all allied health personnel, EMTs, paramedics, the hospital systems, the nurses, the physicians, PAs, and the public health departments. So there was a significant internal and external peer review that was involved as well by those target users in the end, and I'll talk about that under validity and rigor of study. I do want to reiterate that this is an update to the current guidelines, which means that a literature review was done previous, which created the previous clinical practice guidelines, and now they've updated it by including the newer literature and the newer information into this clinical practice guideline. What they wanted was peer-reviewed studies as the basis for all their guidelines. However, the information specifically related to triage in the field was rather sparse. So what they did was they had a epidemiologist do a structured literature review, and that included a database search line in Medline. They searched for English articles from 1966 to 2005 and anything else that was published up until they made the final recommendations on emergency medical services, wounds and injury, and triage, and all related mesh terms. And they also looked at the reference sections of the articles that turned up to ensure that they didn't miss any information. And they ended up with 542 articles, 80 of which they included, and were specifically addressed field triage. The evidence selection criteria, they wanted statistical significance, and they wanted to show that anything that had an alpha error or p-value of less than 0.1%. So they wanted some things that were very clear and statistically significant. Additionally, they anything that had about a 20% positive predictor value of being able to identify the sicker patients, they also included and considered in a general consensus. The health risk and benefit side effects consideration really focused around the potentials of over and under triaging. Again, under triaging someone could result in perhaps death. So they didn't want to create guidelines that would cause this to happen, but they also wanted to try and eliminate the over triage of individuals so that those resources weren't being tied up on individuals who didn't need them. The inclusion recommendations were created by a general consensus, so it wasn't just one individual causing the article inclusion. And the articles, like I said, it was reviewed, and the guidelines were reviewed by both an internal and external review, which included the recommendations by the relevant associations and agencies such as emergency or EMS services, CDC, everyone that could have been affected, all the stakeholders were able to chime in. One of the problems with the development that I think doesn't decrease the applicability of the guidelines, but which could affect the guidelines in the future was that the update procedure wasn't clearly stated. So there's nothing in there that says that every 5 years or every 10 years we're going to relook at the guidelines and ensure that they're still valid, or if we need to make some changes. It appears, looking through the literature review, that it's been conducted approximately every 5 years, but there's nothing outlining any of that, which is a detriment to the future of the clinical practice guideline. As far as clarity and presentation, I thought it was very, very well written, very easily understood. The information was well defined. They looked at the different options, the triage criteria. They even identified what the different trauma levels of the different facilities were. So the reader could understand what is a sick person and what type of facility they needed. Very clear. There was even a table in there which assisted in that that understanding. And all the recommendations were relevant and in depth, and they have some application tools which are developed, which will absolutely help the rollout of the update for the end users. They will have clinical algorithm to follow, and staff training and continuing competency modules, and also toolkits which are tailored to the community size and environment. And all these are available for the end users at no cost. The Center for Disease Control has put it together, and they are the facilitator for getting that information out. So that is good, because one of the potential barriers for applying these clinical practice guidelines would be the cost of getting the information and rolling it out. Now, there still will be a little bit of a cost for the actual training time, but the materials and the instructors, those are not a cost. So that will definitely help, and it should definitely break down some of those barriers. The cost implications, like I said, it shouldn't be a burden on the system to make that happen. As far as the monitoring and auditing to see if it's rolled out and working well, there were no guidelines. That, I think, is a problem, because if they are relying on a decrease in the cost of doing business to demonstrate how well it's working or the viability of the clinical practice guidelines, it's not going to be accurate. There's no way to know if that really is being effective. So that is a detriment to the clinical practice guidelines. As far as any kind of bias or any kind of input, I think that the guidelines were very independent and didn't show any bias, even though 2 individuals have links to some funded sources, one receiving an honorarium for being a consultant on an advisory board for a drug company, and another who was a principal investigator of grants, received some grants from GM and Toyota. I don't think the drug company nor the auto manufacturers, those links were anything that would have caused significant problems, especially they were talking 2 out of 37 people. So it doesn't appear to be influential to the decision-making process. My overall assessment of the guideline was that it was very easily read and understood, provided clear guidance and direction while still allowing for provider judgment, and it is generalizable across the spectrum and wouldn't require excessive education. And it may actually result in the ability to save lives and decrease the overutilization of trauma resources and decrease the cost of trauma. So I would highly recommend the implementation of the guidelines, and I would also recommend that there's in addition add to how they are going to continue to update the guidelines. Pending any questions, that is my presentation. Thank you.